Good morning, everybody. Welcome to, I think this is the third of our case presentations. My name is Professor Paul Tipton. I'm Clinical Director of Tipton Training Limited and also President of the British Academy of Restorative Dentistry. So today we'll be looking again at treatment planning techniques, treatment planning, and also the actual treatment itself of some difficult cases. And today we have a very, very difficult case to look at. So let us start off with our patient. So here's our patient. And as we can see, just looking at her, with her lips at rest, she's showing an awful lot of upper anterior tooth. That's our first glimpse. We then ask her to smile, and what we can see here is obviously a very gummy smile. And as well as the gummy smile in place, the lower lip is overhanging the incisal edges of the upper teeth. Always from a smile design point of view, when we start to look and design smiles, we have to assess the anterior teeth, the upper anterior teeth, and the relationships to both upper lip and lower lip, and especially the relationship for the upper incisal edges to the lower lip is very much when the patient smiles that we want to see either a small gap between the lower lip and the upper teeth or the upper incisal edges touching. But what we don't want to see is, particularly, it's an unaesthetic smile, is when somebody smiles that the lower lip overhangs the incisal edges of the upper teeth. So here, this shows you that the actual teeth in the framework of the lips. So if we go and look at the framework here of the lips, those teeth are too far down. So we've got an anterior occlusal plane problem. We've got an incisal edge in relationship to both upper and lower lip problem. We've got a gummy smile problem, and that's what we can see initially. So let's go through our patient, female, aged 35. We'll see in a few minutes that we've got over-eruption of the maxillary anterior segment of the teeth, and we'll find out why again in a second. Gummy smile, as we've seen, she's got existing crowns on. Those existing crowns are poorly contoured. They're particularly unaesthetic. We are a class 1 div 1 occlusion, which is meaning now that the anterior teeth are not touching. So instead of our normal occlusion like this, our ideal class 1, we're here. And because we're like that, two things have happened. That has happened, and that has happened. So we've got over-eruption of the lower anteriors, over-eruption of the upper anteriors. So we've got now a deep overbite. We've got no anterior tooth contact, and that's something that we're going to have to address, both from a aesthetic point of view, from a stability and longevity point of view, so that things do not move, and also from a occlusal point of view. So we'll show you how we're going to address this particular problem of the class 2 div 1 a little bit later on. We've got over-erupted lower incisors. We've got occlusal plane problems, as we've mentioned, a very short curve of Spey. So we've not got that very nice even average curve of Spey. Remember, the average curve of Spey, approximately 4 to 4.5 inch radius. Here we've probably got something that's 1.5 inch radius, so it's much tighter, much more curved. And as you probably remember from the previous case studies and the treatment planning sessions we've done, if we have a very short curve of Spey, that means that we need steep guidance to disclude it. And steep guidance isn't very good for the masticatory system. And when we look at her teeth, we'll see that she basically needs a full mouth reconstruction. So let's go and look at these problems in more detail now, so we can decide how we're going to try to overcome them. So the aesthetic problems, first of all, we've mentioned a gummy smile. So straight away, your thought process for a gummy smile is going to be that we're going to be doing some crown lengthening. So we need to take some anterior radiographs. We need to probe around to see if this over-eruption is just, and you'll see from those gums that they look very inflamed as well, if the over-eruption and the inflammation is causing pocketing, So if we're going to do some periodontal surgery, will that periodontal surgery mean that we're going to take bone away as well? Or will the periodontal surgery just be soft tissue? So we need radiographs for that, and we obviously need to probe around, sound where the bone is, and decide just how much there is there of extra soft tissue. And can we get away with just soft tissue removal, gingivectomy, rather than going for full bone removal as well? We've got the over-erupted upper anteriors, over-erupted lower anteriors. So basically, we're going to have to take those planes, that upper anterior plane, and move it up, and the lower anterior plane and move it down. At the same time, we're going to have to decide how we're going to create guidance in this case, because at the moment, as we mentioned, they're not touching. If they're not touching and our patient bruxes, then of course, everything is class 2 leverage, and that's going to cause problems with potential fracture of posterior teeth, TMJ problems, muscle problems, periodontal ligament problems, those sorts of things. So looking more closely now, we can start to get an idea of these occlusal plane problems. So if we look at the back straight away, we'll see this more closely on some study models in a few minutes. Here's my occlusal plane going up, coming down and across, going up, and coming down again. And we've got almost a complete overbite here. This soft tissue is very inflamed because of, we've got poor gum margins there, and these crowns obviously will need to be changed in any case. Missing interdental papillae, caused by a couple of things. Could well be that the contact area here is not long enough. Remember, aesthetically, the contact area between two central incisors should be 50% of the length of a central. Here, it's probably more like 30%. We could have some bone loss interproximally, and of course, the distance between interproximal bone and the height of the connector, the contact areas, should be no more than 5 millimeters. Otherwise, you're going to get a black triangle Dennis-Tarnow study. So it's quite possible here that that distance between the contact and the underlying bone is greater than 5 millimeters. So looking at this, apart from the anterior occlusal plane problem, we've got posterior occlusal plane problems as well. And you can just see here, again, problems up and across and down. So we're going to start our diagnosis, obviously, the usual way, occlusal examination, and we're going to look at all the tooth chartings, periodontal condition, occlusal condition. We're going to take our periapicals, OPG maybe. We're then going to go into our planning offsite, and for planning offsite, we need mounted study casts and we need photos. And you can see we've already taken our photos. So we're now going to go in and start to take our mounted study casts. Remember, mounted, this is going to be an aesthetic case. So I want to make sure that when I'm doing my face bow is parallel to the eyes. So my technician has got the interpupillary line, if that's the line I'm going to work at, has got the interpupillary line in front of him, because that's the top part of the articulator. So we have our reference point. Now, on our diagnostic cast, we're going to look at the occlusion and work out what occlusal problems there are and our potential options for treating them. So our occlusal problems as we see them at the moment. We've mentioned we've got this uneven occlusal plane. We've got this very, very tight curve of space. We've got lack of anterior tooth contacts. So we've got no anterior guidance from the anterior teeth. As we mentioned, that means we've also got class 2 leverage. So we've got a lot to sort out here as we go through our reconstruction. Not only aesthetic problems, but major functional occlusal problems, which will, of course, mean that if we don't get it right, the longevity of our restorations will suffer. And remember, what we need from restorations, you need predictability. Predictability will only come if you get the occlusal scheme correct and you get stability. And from our restorations, we want longevity, we want aesthetics, we want minimum tooth preparation. But everything is going towards that goal, that major goal for you of predictability. Predictability, stability over a long period of time. So we're going to be looking at our principles of occlusion here. And we know that we have our standard 5 principles of occlusion. And in this particular case, 2 of the major problems are that we've got no anterior tooth contact, and we're going to try and find a way around that. That way we're going to look at today is going to be long centric. So we're going to have a discussion about occlusion. I'm going to have a discussion about long centric today. Not a topic that we've dealt with previously. We do this during our modular course on the advanced occlusion module. And from time to time, when we're treating class 2 Div 1 patients, then the long centric is something that we need to take into consideration, one of our options. So let's look at our general treatments of the class 2 Div 1 case, restoratively. Okay, so we have got options. Our major problem, as we've just identified, is no anterior contact. Means that if my patient bruxes, remember, 25 to 30% of your patients will be bruxing tonight. Everybody probably will brux at some stage, okay? So if my patient bruxes on my reconstruction now, and again, remember when the patient bruxes on their own teeth and a tooth breaks, they come back saying, "Doctor, I've broken my tooth, please fix it." When you've done the reconstruction, and the patient bruxes and breaks your restoration, the patient comes back and says, "Doctor, I've broken your restoration. You fix it, please." And that "you fix it" means obviously at no extra cost. So as soon as we get into restorations, we have to make sure that we are protecting them. And that gives us our predictability. And our 5 principles do that. However, if we cannot get anterior tooth contact, we cannot now have guidance on the anterior teeth. That means that if we do have guidance, we're always going to have anterior guidance. Our anterior guidance is now going to have to be potentially on our posterior teeth. So what ways have we got around doing this? So let's go through them. The first one is to restore to our standard ICP. Don't go back to our AP. Go back to restoring to our standard ICP. No anterior tooth contact, because remember, if we now take our patient back to our AP, that is likely to happen. Remember, 90% of our patients have got a slide. That slide involves vertical and horizontal all the time. So there is always a horizontal component. So if I take my patient back to our AP, that overjet that we've got will increase. It may be increased by a minuscule amount. It may be increasing by 1 or 2 millimeters. So our first option is to restore to our intercuspal position. So we're actually not making that overjet any worse. And then once we've restored, done our full mouth reconstruction, we do it to our principles of occlusion, but we cannot get a mutually protected occlusion because we have no anterior tooth contact. We're not working to RAP, we're working to ICP. We've got no anterior guidance on our anterior teeth. That means that probably when we move from side to side, forwards and backwards, we'll have posterior interferences. So the way in which we can get around that in a case like this is to give somebody an occlusal split. So at night time, when they are bruxing, clenching and grinding, remember with 10 times, 5 to 10 times the amount of force, then they're bruxing, clenching and grinding on the occlusal split. But remember, the occlusal splint becomes mandatory in these sorts of cases. It's not, I'll wear it if I feel stressed, because then the damage may already have occurred. So our patient needs to understand that this is something that is now for life. We're reconstructing you. I am taking charge of your restorations in your mouth. You're giving me the finances to do that. I have to give you some form of predictability, stability, and that then has to be an occlusal split. So that's our first option. Second option, and this is probably my preferred option, is orthodontic surgery. Something like a mandibular split and moving the anterior part, a sagittal split, moving the anterior part slightly forwards. So instead of the teeth being here, the anterior segment is moved to here. That often needs to be done with orthodontics. So orthodontic surgery, orthodontics, I'm grouping together. Let's see potentially if our patient can have ortho. So an orthodontic view may be useful. to see if there is some way of retracting the uppers or moving the anterior segment forwards so that we can get some anterior tooth contact. Or possibly if we can move them forward so we get anterior tooth contact if we build in a large palatal shelf. You'll see in this instance at the moment, we're probably about 5 millimeters away. So there's no way I can build in a 5 millimeter shelf. But with orthodontics, if I can get to that position, from there to here, maybe I can build in a palatal shelf, which will give me anterior tooth contact, which will give me guidance. Finally, and the one that we're going to be looking at today, is long centric. So those are our options. There are many more options, I'm sure, but these are our 5 major options when we're looking at treating a class 2 Div 1 patient who has no anterior tooth contact. And we need to give them anterior tooth contact so that when they brooks in class 3, not class 2 leverage. That gives us longevity, that gives us predictability. So what is long centric? So we have, if you like, three concepts. We have long centric, we have wide centric, and we have freedom in centric. And these are very much Pankey-Man, Schuyler, Dawson concepts. Some patients need them, some patients don't. It's more complex to build in long centric than it is to build in a normal standard 5 principles of occlusion. We can have long centric on anterior teeth, we can have long centric on posterior teeth. Let's look at long centric on anterior teeth first of all. And this is all to do with the mole feeding position. So a question to you is, you've done some anterior crowns for somebody, and upper maybe 3 to 3, 2 1 1 2, and the patient's been lying back. You've been working either to intercuspal or to RCP equals ICP around RAP, either one, doesn't matter at this stage. And as far as you're concerned, the bite is correct. As the patient's lying down, the patient has said, yeah, feels comfortable. You've got slightly heavier contacts at the back, slightly lighter contacts on the front. So you have your mutually protected occlusion. You have your guidance on the front teeth. So they're discluding the posteriors. You're completely happy. You take your gloves off. You sit the patient up. You say, have a rinse. We're finished for the day. Patient sits up, has a rinse. And when they're sitting up, they say, hold on. No, I still feel now sitting up that my front teeth are hitting first. So what do you do? The usual thing we do is we say, well, that's perfectly normal. Because again, if I'm now lying down like this, my back teeth will hit first. If I'm sitting up, especially if I put my head slightly forwards, then my front teeth will hit first. So as far as I'm concerned, as a dentist looking after your teeth, I'm perfectly happy with that. And you can go through the explanation that when you're lying back at nighttime, that's when all the bruxing forces come in. That's when I need to have your occlusion perfect. When you're sitting up, you're talking, you're chewing, etc. Your teeth are only in contact for 5 to 15 minutes during the daytime. It doesn't realistically matter. Most of our patients will accept that, will get away and walk out. Some patients, especially those who are maybe occlusally conscious, these are patients who maybe had a lot of restorations done in the past, understand a little bit about dentistry, or they've read around it a little bit, and some of them can be very, very occlusal conscious. So they may say, sorry, this does not feel right, I'm not comfortable. Okay, what are we going to do then? We've got the bite right lying down, so now we have to get the bite right sitting up. Okay, so what do? We have our patient lying down. We put in red marking tape on the front teeth, tap them up and down so we get a contact. We now sit them up, ask them to push their head slightly forwards into what we call the mole, M-O-H-L, feeding position. Okay, so this is now eating food. And in that forward position, we then sit the patient up. You're now standing up. You put a different color, let's say blue, in place, and ask the patient to tap up and down. So what do we see? On that inclined plane, we're going to see one mark here, which is my lying back position, and we'll see one mark here, which is my sitting up position. And there'll be a slight difference between the two of them. What we do now for those patients is maintain the lying down position, in this case it's red, and adjust the blue position, the sitting up position. So what will happen is eventually we will have a contact here for the lying down and a contact there for the sitting up, but they will be on the same horizontal plane. So we're creating a horizontal shelf, purely horizontal shelf on the anterior teeth. So instead of the lower incisors contacting an inclined plane, they're contacting this shelf, which means that they can move forwards and backwards. So in the sitting up position, they can still feel their back teeth contacting. In the lying down position, they see their back teeth contacting, they can feel it. You've created long centric on the anterior teeth. And we only ever do that for patients who complain that, sorry, my bite doesn't feel right when we've done it lying down. Yeah, we're not going to be talking anymore about that. The next one is long centric on the posteriors. So imagine a case where, for whatever reason, we're not restoring the anterior teeth, or we're restoring the anterior teeth, but the distance between the anterior teeth is too great, as in this case, to put on a palatal shelf. So now one of our options is to create long centric on the posterior teeth. And what that entails is providing these same horizontal ramps, horizontal shelves, but creating them on posterior teeth. We create them on posterior occlusal surfaces. And what that does is allows the mandible to slide perfectly horizontally on the back teeth until the front teeth touch. And then we go into protrusive and lateral movements and the back teeth disglued. So this now means creating a new shape on the occlusal surfaces of the upper teeth. We don't do it on the lowers, we do it on the occlusal surfaces of the upper teeth. And where the lower buccal cusps would normally fit into the occlusal surface of the upper tooth, we raise that occlusal surface, lower the lower buccal cusp, and create this horizontal plane. So in the middle of the tooth, there's the cusps. Instead of the cusp being like this, in the middle of the tooth where the cusps are, there is a horizontal plane just there. And that allows the lower buccal cusp to slide forwards and backwards, purely horizontally, no vertical movements, until the anterior teeth touch, and then the anterior teeth disglued. So this is very much something which you're involved with conceptually, you're involved with the treatment planning, but this is very much something that your technician will do for you in his wax up, in the prototypes, and in the final definitive restorations. So let us come back to our case. With the theory part behind us, let's come back to our case and let's go and try and see how we now do this case. So we're looking at the upper study casts, and as you can see, we've got this large amount of soft tissue here. We can see that we've got poor shaped upper anterior restorations. Looking from the side, this is now the view you're going to get from the side, and this is our huge problem about the occlusal plane. Look at that. What we're wanting realistically to have is a fairly flat occlusal plane. So that means that the side teeth are going to have to come down, upper teeth are going to have to come up. Okay, so the same thing both sides. We look at the lower, and of course the lower we have the similar sort of thing. We have our occlusal plane which comes down, it then comes up, and it goes across, and then we come down and then back up again. So we have the same problems of the lower occlusal plane, or the opposite options of the lower occlusal plane. Adding into this, we've got restorations already on many posterior teeth, and we've got worn and chipped lower incisors. So all of this is going towards our patient needs a full mouth reconstruction. And as you know, the starting point for all this is diagnostic wax up, prototype, prep guides, etc., etc. So we're going to go through exactly that same diagnostic planning. Initially, before we start to do the planning, we've got to think about vertical dimension. Now, vertical dimension, there's two parts to it. Number one part, we change vertical dimension if we think that the face needs to be changed. Okay, and we do this mostly for older patients who've lost vertical dimension. Most people will, if they clench and grind their teeth throughout life, lose vertical dimension. So the older patient, their nose-chin distance has got far less. And by opening up the vertical dimension, you give them a better proportion. We call this very often the dental facelift. And we put the face into better proportion. We lose some of the lines that we have on the side of the face. And most of our patients of a certain age, I'm thinking more patients in their 50s or 60s, benefit hugely from that. So they get a lovely smile makeover and they have an improvement facially. And if we do that by a minimum of 5 millimeters, we know that the public will respond and look at them and say that they look younger. And most patients in their 50s and 60s would love to look younger. So number one, we increase vertical dimension to improve aesthetics. In this case, our patient's 35. She doesn't have any lines and wrinkles. Her face is in the correct proportion. Number two, we increase vertical dimension often so that we can gain space for restorations. Okay, now again, let's look at this lady in terms of the space for restorations. We know that these teeth are going to have to be moved down to here. So we're going to be reducing the incisal edges in any case. So it's not exactly like we need to gain space. We need to lose space in effect. We look at the upper anterior teeth, just go back again. Upper anterior teeth, our occlusal plane needs to be here somewhere. So I'm going to have to grind the occlusal surfaces, incisal edges, to get my teeth back up there. We look at the posterior occlusal planes, and I'm going to be bringing this posterior occlusal plane down. So in this instance, space is not really a problem to me. I'm going to distribute the space. So I'm going to work at the existing vertical dimension, okay? A case where we don't need facial aesthetic improvement. I do not need to create space, but I am, of course, going to be working around RAP or around RCP. So if we're going to increase vertical dimension, we go and do it. If we're not going to, then we're going to work our existing facial dimensions. And our next protocol, our next thought process is occlusal planes. Okay, we know that our occlusal plane in this case is totally wrong. So we have to go back to our standard concepts of occlusal planes. And we're going to give our patient new upper and new lower occlusal planes. So for the occlusal planes, you know this information. We've been through this many times with you on previous case studies, on treatment planning, on treatment of the worn dentition. We've got many webinars where we've been through this with you. For our occlusal plane problems, when we're establishing a new occlusal plane, we go to the lower occlusal plane first of all, create a new lower wax up, then we do the upper, and we do that because for an occlusal plane, you need to have 3 points. For a plane, 3 points. 2 posterior, 1 anterior. My 2 posterior reference points are the retromolar pads. We know that our curve of Spey, our posterior occlusal plane, goes through the retromolar pads. So we're going to use that as our 2 posterior reference points, and we're going to make that the superior third of the retromolar pads. And then we're going to look at our anterior reference point. And our anterior reference point, as we know, is the lips at rest when the patient goes and we look and see how much tooth tissue there is there. And we now try and work out for the patient's age, this case 35, how much tooth tissue should be on display. And that's roughly going to be about probably 3/4 to 1 millimeter. So we'll now take a reading with our lips at rest. Emma, how much tooth tissue does she show? She's showing about 2.5, 3 millimeters. We're going to reduce by about 2.5 millimeters the incisal edges. And that will now give us our new reference point. So the first thing we do on our mounted study casts is our technician will now grind down the lower anterior tooth to the position I want it to be in. He'll then use a Bowles plane analyzer. He puts the Bowles plane analyzer so it goes on to the anterior reference point, which is the new incisal edge position. and also contacts the retromolar pads. And now he waxes up all the rest of the lower occlusal plane to that position. So here's our mounted study casts, and my technician has got the Boyle's plane analyzer. Remember, the Boyle's plane analyzer has got waxed into it. It's a piece of plastic. You can buy these readily from your dental labs. If you have any problems, contact me and I can get you or point you in the right direction. Essential piece of kit, guys, essential piece of kit. Your lab technician has to have one. Without that, you can never do a full wax up properly, okay? So you can, in effect, also use the Broderick flag, okay? But one of the two, Broderick flag with the Danar system or the Boyle's plane analyzer. Far easier for me to use the Boyle's plane analyzer. So this is rested on those three areas and everything else is waxed up to it. As you know, the Boyle's plane analyzer has in the curve of Spey, curve of Wilson, okay? Both of those roughly a curve with a radius of 4 to 4.5 inches. And from there, we complete our lower wax up first of all. As you know, we always do the lower wax up first of all, and then we do the upper wax up down to the lower wax up. And the reason for that, the only part of the mouth when we're doing new occlusal planes where we know that our original occlusal plane goes through is the retromolar pads. So here's our new curve of Spey. A lovely curve with a radius of 4.5 inches, 4 to 4.5 inches. My anterior occlusal plane now reduced by about 2.5 millimeters, and I have a very, very nice starting point. So I built up the side teeth, brought down the anteriors, brought down the posterior slightly to create that lovely curve of Spey. Now we go to the upper and we do exactly the same thing with the upper. We take our patient and we say, okay, Emma, and how much tooth tissue should she show at the age of 35? This varies tremendously, and it's not just an age thing, it's also about the lips. It's also about how long is the upper lip, the shape of the upper lip. So the shorter the upper lip, that's the distance from the undersurface of the nose to the lip, the shorter the upper lip, the more tooth tissue we should show. The longer the upper lip, the less tooth tissue. Also the type of lip. If we have thin lips, then we'll show less tooth tissue. If we have everted, full lips, then we'll show more tooth tissue. So it's not just an age thing. It's two other things we have to take into consideration. Because with big lips and with short upper distance here, we have something called central incisor dominance. Okay, so if we look at smile design, we have our option of golden proportion, and we also have the option for big lips of central incisor dominance, where the two central incisors dominate the smile completely. Those are our two options when we're assessing the amount of tooth tissue to show. So if this varies tremendously, and it's going to vary for someone in the region of 30 to 35, from probably 2 millimeters up to about 5 millimeters, depending on the lips. So we make an assessment, and in this assessment, I'm going to want to, she's got a reasonably short upper lip, have probably about 3 millimeters or so on display. So we measure the amount she's got on display to start off with, far too much. We then measure how much we need to reduce off the incisal edge until she's showing that 3 millimeters approximately. And we then say to our technician, okay, now reduce the anterior occlusal plane by that amount. So we now know the anterior reference point. And here's our anterior reference point. We've done some crown lengthening. Please look, remind yourself of the occlusal plane, what it was like beforehand. Our occlusal plane went up and it went down. Our occlusal plane again went up and it went down. So what we've done here is we've reduced the height at the back, increased the height in the middle, and reduced the height at the front. So we've got a very, very nice even occlusal plane. Golden proportion, at the front of the mouth, canines nicely tilted inwards. We're now ready to go. So from our lower, we've got our study model, we've got our waxed up, we now have our prototypes. And as you know, from the prototype point of view, the prototypes are always done in 3 sections. So we have our anterior section, posterior section, all splinted together. So we have lower 3 to 3 ready to go. We have lower right splinted, lower left splinted. And our next stage will be to go and transition from where the patient is to their new prototypes. So let's go with our prototypes. This is our next stage, is our prototypes. And again, in the upper, exactly the same thing. We have our upper 3 to 3 splinted together, lower posterior, upper right posterior, upper left posterior. And we have now our prototypes in the lower. Everything from our prototypes is matching exactly our diagnostic waxing. Our diagnostic waxing is matching all our thought processes at the moment, all the information we know historically, scientifically, that's going into this case. And we're also taking into consideration our long centric that we need to provide, because these anterior prototypes will not be touching. The lower incisors will end up touching here. We'll get contact from the canine back, but we're not going to have any contact on our upper incisors with our lower incisors. We also get our prep guides made. And remember, these are our prep guides. Our prep guides are a little suck down that goes over the top of the stone model of our wax up. Alternatively, goes over the top of our prototypes. Those things should be exactly the same. And of course, we cut these down. If we're going to do the anteriors first, then I'll cut across there and use the anteriors, same way, cut across here and across there. So we have 3 sections. We put them on the anterior teeth. They rest on the soft tissue and we drill holes through. And now I can push a periodontal probe through. So I'll put lots of little holes, just take a very fine diamond burr and just go zzz, like this over the whole labial surface, incisal edge, palatal surface, so I can push through with my perio probe in all these different areas of the tooth, and I can assess how much tooth preparation I've done. For this case, we're going to be doing zirconia anterior restorations, so we're going to be using about 0.7 to 0.8, 0.9 of a millimeter, just short of 1 millimeter in terms of space. So we're all ready to go diagnostically. Okay, the next stage is to start to do this in the mouth. And the first part of that is our pre-restorative stage, because she needs some crown lengthening doing. Okay, so we want to get rid of that excess tissue. Fortunately for me, in this case, we've probed and we've got large pockets around here. So this is going to be a gingivectomy. So we go and do our gingivectomy. Remember, with a gingivectomy, we as dentists and lay people very often have a different idea of how much a gummy smile is. We might look and see 2 millimeters of soft tissue there and think to ourselves, that's a bit gummy. Our lay people do not look and say that's a gummy smile, as in they do not mark down photographs of people with excessive tissue until it gets to 4 millimeters. So we have to work within those parameters of, if our patient thinks it's gummy, okay, by all means do something about it. But most of the population will only assess that you've got a gummy smile if they're seeing more than 4 millimeters of soft tissue. So here we've done our diagnostic wax up, and the next stage is to go and give ourselves a guide to doing the perio surgery. So in this case, our guide goes on, and this is just a little simple plastic stent that goes over the top of the posterior teeth, and it goes in place, and with an indelible pen, we now mark around with the indelible pen the new position of our soft tissue. And remember, always with periodontal surgery, guys, make sure the patient understands that this is very often not a one-off procedure. Most of the time, we can get away with it just one amount of perio surgery. probably 10%, 15% of the times, we will need to go and do a little bit more just to get it exactly right. So always say to your patients, we do this probably in 2 stages. Our first stage is the gross reduction. We then have to wait and see where it settles, how good your hygiene is, how much shrinkage there is, and that's down to your biology. I cannot say anything about that. Everybody is different. And then once that's happened, at 3 months, we'll assess, and we may or may not need to do a little bit more. So always, this is initially a gross amount of reduction. So I'm doing my gross amount of reduction here. Do that with a scalpel by all means. Do it with electrosurge, as I'm doing here, just with electrosurge, going around and cutting the excess tissue away. I'm doing a little bit just on the canines as well. And once that's been done, then we're into doing our prototypes. So you can do one of 2 things here. You can either decide immediately at the time of doing the gingivectomy that you're going to put your prototypes on, which is what I'm going to do here. Why on earth do I need to leave my patient with an even greater unesthetic result? So now she's got less gum, but she's showing the roots and she's showing the margins of the crowns. So I'm going to do this all at the same time. So I'm going to get my patient in early. I'm going to do the gingivectomy with the electrosurge, so it heals pretty well. I've got some racestriptine solution if I need to be able to stop any other little oozing of blood. And then I'm going to do my prototypes at the same time. So I'm now going to be prepping upper 3 to 3 and lower 3 to 3. Now we've got our wax up, and our wax up tells us, again, from models, from photographs, from our assessment, exactly where the occlusal plane should be. But very often these things look different in the mouth. So I'll have my prototypes ready. I'll do my preps. Going to use my preparation guides to do my preps. I'll fit my prototypes. I'll reline my prototypes, and then I'll sit back. I'm going to let my tissue heal, and I might well still play around with the anterior occlusal plane and just get it what I think is right, now looking at the patient's face and the incisal edges in the patient's smile. So never feel that you've done something wrong if you have to go back and redo some of the prototypes or adjust the prototypes. That is part and parcel of the service that you're offering. It's a bespoke service that you're now going into the mouth and adjusting it to that very same person. So we start off with prepping the upper anteriors. So here's the upper anteriors re-prepped. You can see that we've just still done our surgery. So we're going to re-prep those. From a preparation point of view, I'm going to have to be a little bit heavier now on the incisal edges. We've reduced those incisal edges by about 3 millimeters. So I'm going to be a bit heavy on the incisal edges. Fortunately, one's already been root filled. We've got a little bit of caries, so the pulp has shrunk back there. We've got no pulpal exposures, although we're quite close. And very important in situations like this that you dentine seal. So don't go and do heavy tooth preparations and then not dentine seal. You've got a chance of losing the pulp. So we dentine seal in every single case in any way, but even more important when you're doing heavier tooth preparations. And now we take our prototypes, and here's our prototypes. And we're going to put Luxatemp into the prototypes. We're going to put them in position. 2 ways you can do this. You can either do it freehand or you can do it with a jig. I usually like to use freehand because it gives me a little bit more ability to move things around. So what I will do will be to fill up this with Luxatemp. Remember, it sets pretty quickly. I'll then come round to the front of the mouth and I put it onto the preps at the front of the mouth. Why? Because I can see occlusal planes more easily. I can get an idea of aesthetics far more easily than my patient lying down and me looking over them. So I'll do it at the front, I'll put it in place, and I will wobble it until I feel the anterior occlusal plane is correct and it's parallel to the eyes. I just need to hold it there now for about a minute. The Luxatemp will gel, done my job. Other ways, you can get a little jig, an acrylic jig, which fits into the palate. So you get your Luxatemp, you get your prototypes made, And on the model, then the technician produces a little jig, acrylic jig, which fits into the pallet, fits over the incisal edges of your prototypes, so that when you're fitting them in the mouth, you simply seat the acrylic jig in the pallet, and that gives you the exact position of where these prototypes should be from our diagnostic wax up, etc. So 2 ways of doing that. So here's my prototypes now in the mouth. And you'll note that initially I've not done the lowers. This is just me looking at the uppers to start off with. I'll go on and do the lowers in just a minute, but this is my initial view. Nicely relined, trimmed around the margins so they fit the margins really, really well. This is so important if I'm going to get good gingival healing, that you spend time. And I would normally, for an upper 3 to 3, give myself an hour to reline, to then trim the margins, to put them in place, to try them, to get them right, to put some Luxor glaze over the top, and finally cement them in place. That's a full hour. So you do need to give yourself plenty of time, and then you're going to get good healing. We've now done the lowers, and this is a view from a few weeks later. As you can see, we've put our patient on a little bit of Corsadil just to help the healing, but you can see the soft tissue is responding very, very nicely now. We've got our new upper occlusal plane. We've got our new lower occlusal plane, as close as we can make it to what's happening on the diagnostic wax up. There may have been a little change here and there. And now we've been assessing for function, we've been assessing for aesthetics and phonetics. And we're now ready to go to our restorative phase. And our restorative phase is going to be, as you know, in stages. So we're going to run through our stages now. And our stages are always the same. So they're going to be to get the upper anteriors and lower anteriors prepped, fitted. Then we move on to one side, the right side, get them prepped, fitted, move on to the other side, get them prepped, fitted. And the way in which we go about them is we take off the upper and lower prototypes. We re-prep. Remember, I've prepped just to the gingival margin. My soft tissue is now healed. Okay, so we may get a little bit more shrinkage. And I eventually want to put my margins just underneath the soft tissue, maybe 0.5 millimeter underneath the soft tissue. If I'm doing a verti-prep, I don't have much tooth height, so I'm losing resistance retention form. Or if I'm working with a post, then I may well put that margin using a verti-prep up to 2 millimeters subgingivally. But for my standard, for my zirconia, verti-prep now is going to be 0.5 millimeter subgingival. So I'm going to re-prepare a margin if in fact you're going to do one, or you're going to just re-prepare generally until you are underneath the soft tissue with your verti-prep marginless or your chamfer for zirconia, whichever way you want to go. Once you've done that, we will take our impressions. So we're going to put retraction cord in, usually 2 retraction cords. We'll take our upper and lower impressions. We're now going to do a face bow. We'll do our jaw registration around RAP. Because I've changed the preps, I need to reline, mostly just the margins. So I'm going to syringe some Luxor around the margins, put it back into position. Usually what I'll do is I'll use the Luxor not on the prototypes, but I'll use it in the mouth. So I'll stop any oozing, and then as though I'm taking an impression. So I have the Luxor in my syringe, and I go to the mouth, dry the tissue, as though I'm going to take an impression, this time with the Luxor. So I'm syringing the Luxor around the gingival margin area, and then I'm going to take my prototypes and seat them. Rather than adding it onto the margin and seating, I'm adding it around the soft tissue and seating. And again, we wait for that to set, take it off and trim around the margins. Once we've done that, we're going to refit the prototype. So put temp bond back in position, uppers and lowers, and then finally, I'll take impressions of the upper and lower prototypes in position, because remember what I'm asking the technician to do is one word, copy. Please copy my prototypes. Okay, that's what I want him to do. And he can do that very easily these days with either scanning, using putty matrices, or using the old-fashioned anterior guidance table. Next stage after that is I'm going to fit the upper and lower anteriors. Now, there shouldn't really be any reason, if you do this properly and you spent time with your prototypes and the function is right, that means the shapes are right, there should be no reason why you need to go to a biscuit baked triangle. Any adjustments that may need to be made, probably will be made, will be very, very small adjustments, easily polishable. So there's no real reason for you to go to an intermediate stage. The only reason you go to an intermediate stage is if, for whatever reason, you are not copying something that's working well in the mouth. So we fit. Next stage is now going to do exactly the same thing, but to one side. So I'm going to take off my upper right posteriors, my lower right posteriors. I'm going to re-prep if needs be. My margins might be right. My margins may need some changing. Okay, so re-prep if needs be. Once you've re-prepped, fine, then we're going to go and take our imps, uppers and lowers, again, 2 retraction cords as normal. We're going to take a face bow again. We're going to take a jaw registration, again, between the preparations. My favorite jaw registration, guys, I have to tell you, is Durolane. I do use silicone from time to time, and if I'm going to use silicone, then it needs to be nice and thick and rigid. Thin silicone around all of the arch is pretty useless. It's too flexible. So for that reason, we only use our silicone bite registration paste between preparations. So my silicone bite will be there between the preps. However, we're going to get a more rigid bite if we do it in Durolane. So I like to go and take a lower buccal cusp, add some Durolane on, move it up to the upper, maybe palatal cusp. Then once it's set, take a little bit off it, add some more liquid Durolane onto it, and then just get the patient to close into it. And I'll get a nice indentation between lower buccal cusp and upper palatal cusp. And that is then very, very rigid. And the models seat or they don't seat. So we've done our jaw reg, we then reline and retrofit again, and obviously we'll take another impression, upper and lower. Alginates can be fine for this. If you want something that's a little bit better, then you can by all means use putty and wash. The problem with using putty and wash, whenever you come to do it, guys, is that it can easily take your prototypes back off again, because the putty and wash work that well and are that sort of, you know, sticking that much, getting really good reproduction and pretty firm, they very often take the prototypes off. So if you really do need to have that level on the posteriors, especially of accuracy, recording the exact shape of the occlusal surface, then by all means go and take a putty and wash, but be prepared that it will take the prototypes off, and then you have to go and dig all the excess temp bond out and re-cement them again. So next stage after that is fit the upper and lower posteriors. Then we go and do exactly the same thing to the left-hand side. I won't go through it again, but it's exactly the same thing. So let's go and start off in this journey now in doing the final phase is we go and re-prepare the uppers. In this instance, we're doing zirconia, as I mentioned, about a 0.5 millimeter margin subgingivally. This is before we got back into doing vertipreps. Nowadays, I would do a vertiprep margin. So I'm taking less tooth tissue away axially all the way around. The vertiprep has given us the opportunity now to be much more conservative with our axial reduction. So if I take less off the margin, it means I have to take less off the axial surfaces. So it's far better for our patient. However, remember, coming with the vertiprep, it's a much more difficult technique for your technician. The restorations are much thinner, they're more difficult to seat. So you have to go through this with your technician first of all and make sure you understand the protocol. So we're now into the laboratory and he does his usual 2 models. We have a stone model, which is what he takes the crowns and puts them back onto. and we usually have silver dies or removable stone Pindex for him to work on the individual crowns. So we've got upper and lower, just showing you the solid models here, which he retrofits the crowns back onto, so he can then get exactly the right shapes of the contact areas. And we're now going to go and fit them. So here again on the model, we've got our new restorations, looking a little bit longer because they're going subgingivally now, of course. And our lowers, exactly the same, a little bit longer because we're going subgingivally. Palatal aspects now more concave, because we're not going to try and get that anterior tooth contact. We're going to be relying on this long centric. So we fit those in the mouth, and then we go to the opposing side. So I'm now going to my right-hand side, and let's show you what this long centric really looks like. You're not going to see a huge amount, but what you can see here at the moment is, with the anterior restorations now in place, there is a large distance between the incisal edges here and the palatal aspects. And that large distance is in the region of about 3 to 4 millimeters. So what we have to do is we have to have the lower buccal cusps sliding on the palatal surfaces on the right side and the left side, about 3 to 4 millimeters, until the anterior teeth touch, and then the anterior teeth will disclude. So once we get these 3 to 4 millimeter ramps in the occlusal surfaces, okay, and we're going to put those on the occlusal surfaces here. Once we have those 3 to 4 millimeter ramps, outside of those ramps we can have anatomy, because our patient is now with anterior teeth in contact and can disclude. And then we're going to do exactly the same for the other side. So here's our other side with our restorations in place. Again, you can see the amount of overjets that we've got here. And we're going to need 3 to 4 millimeters of movement before we get contact. And again, you'll see in a couple of minutes, the occlusal surface is much flatter, where our technician picks out a buccal cusp and allows that buccal cusp to move purely horizontally. Okay, so here now a closer view. We can see no palatal cusp, an area in the middle of the occlusal surfaces where we have this flat area. Same thing here, no palatal cusp, flat area in the occlusal palatal area. So they will look slightly differently when you look at the back of the mouth. Hold your head back, but realistically, they're not going to be seen by anyone. And those lovely horizontal areas just allow those lower teeth to drift forwards, purely horizontally. That's the most important part, purely horizontally. We increase stress, that class 2 leverage we talk about. That class 2 leverage comes in because we clench and grind on inclined planes. Okay, remember, look at the canine. Let's just go back and look at the canine. Okay, patient's going to clench and grind. He clenches and grinds like this. As we know, if guidance becomes shallower, we don't put as much stress into the masticatory system. As the guidance becomes steeper, there's more stress that goes into the masticatory system, and we want to avoid stress. So now what we do at the back of the mouth, we have the initial guidance totally horizontal. So there's no stress whatsoever from sliding. The only stress we might get is from clenching, like this, but the actual bruxing from side to side, there's going to be no stress because we're gliding on purely horizontal surfaces. And again, a little bit closer view. Flat area, flat area, flat area, flat area, flat area, flat area, flat area. And this is just something that the technician will work out. And the whole point of this is the lower incisors will move 2 to 3, 4 millimeters, now touch. And as soon as they're touching, we can start to put our anatomy onto the posteriors, because then the teeth will disglued. And so in the mouth, again, we've got our flat area, flat area, flat area. You can see that really nicely just here. Same thing, flat area, flat areas, and flat area there. So our lower buccal cusp hits here, slides forward 3 millimeters, then we can have anatomy. Lower buccal cusp hits here, slides forwards 3 millimeters, then we have anatomy. Exactly the same thing on all of the posteriors. Remember, this is a thought process for you. It's an occlusal diagnosis and plan. It's your technician that will fulfill all this. And so here we have our finished reconstruction. We're just about to finish up our case now. Our upper reconstruction, lower reconstruction, again, we've put those lovely curves of Spey, curve of Wilson in place. Our flat areas on the upper posteriors. And as we go into a right lateral, remember we've got contacts on our canines, it's just the long centric, the protrusion. If we're going to put the same concept into lateral movements, that means that the canines were not contacting. We would then call that a wide centric. If we did the long centric and the wide centric, we would call that freedom incentric. But in this case, we've got the canines in contact, so lateral excursion we exclude. It's just the protrusive guidance that we want to be remain the same. And again, into our left lateral, we have disclusion of both sides, a couple of millimeters at the back. And in protrusion, once we've got the teeth into contact, then the teeth will continue and slide forwards and disclude the rest of the teeth. So there's our finish line. And remember, we discussed that we wanted to have the incisal edges touching the lip as opposed to the lip overlapping the incisal edges, which was there at the very beginning. There's our patient's final smile. And this is where we started. And this is where we finished. Difficult, complex case, dealing with periodontal surgery, dealing with anterior aesthetics, occlusal planes, vertical dimension, occlusal principles, long centric. So it needs a lot of thought process. In order to keep her stable, she wears an occlusal splint at night time. Again, most of my patients are given an occlusal splint. So thank you very much for listening to this. I hope it's given you some insight into how we treat some of our more complex patients and the stages which we go through. I can see that we've got some questions, so I'm very happy to remain behind now and answer those questions. As I say, I hope you found it useful. We've got many more of these case studies. And from my point of view, once you've done the treatment planning sessions with us and you understand how you treatment plan generally, I think it's a great benefit to see how somebody treatment plans each individual case. And what you'll find with all of these cases that we're going to be showing you, we've got about 15 to 20 in total, they're all done exactly the same way. So once you understand the principles, everybody will fit into a box. Sure, some things might be slightly different. In this case, it's a long centric, but we're still looking at our 5 principles and assessing them. Some people may have periodontal surgery, sure, and we put it into our treatment plan. But the plan is exactly the same. All we do is just insert different parts into the plan. So at no stage should you be able to look at a person, look at a patient, and go, oh, I just don't know what to do. Okay, you treat it logically, you get your plan, you put the patient into the top and work through your plan. And from time to time, you'll have decisions to make. What shall I do here? And maybe you think about it, you get some more advice from somebody else, and then you continue with your plan. And that's what we do. So again, thanks very much for listening, and we're happy to take some questions now. So I'm going to go on to the questions. Okay, so first one's from Raddy. Good morning, Prof. Tip. Does the occlusal splint provided to patients class 2 1 restored to ICP establish proper anterior guidance? Yes, that is the idea, Raddy. The occlusal splint takes over from the fact that we cannot restore to our 5 ideal principles. Okay, so with the class 2 div 1 restore to ICP given the splint at night time now has those 5 principles, but it puts the condyles back into REP. It gives a mutually protected occlusion. It gives anterior guidance on the anterior part of the splint. It disglues the posteriors, and it gives stability to the joint. So the answer is yes, it's there, and it establishes the true 5 principles. So in this case, it would be a Michigan splint, class 1, class 2 patients, Michigan. If it was a class 3 patient, and for whatever reason I could not establish my 5 principles, then do what you can, and the occlusal splint re-establishes the 5 principles. However, as I mentioned, really, really important, your patient's got to understand they have to wear it. This is not, okay, wear it when I want to. They have to wear it. Otherwise, we can start to get damage to the musculature, the joints, periodontal ligaments, or our teeth start to chip our restorations. Jeff, we're trying to obtain the 2 contacts of the long centric horizontal plane. How do we ensure the masticatory forces along the long axis of the anterior teeth? Ooh, better read that one again now, Jeff. Trying to obtain the two contacts. I'm not sure what you mean, the 2 contacts. Presume you mean the 2 contacts, the contact lying down and the contact sitting up. How do we get them in the same horizontal plane? How do we ensure that masticatory forces are along the long axis of the anterior teeth? So first of all, masticatory forces are not down the long axis of our upper anterior teeth. Okay, we're hitting like this. They may well be down the long axis of the lowers, but not the uppers. So we're always going to have off-axis loading on the upper anteriors, but hopefully not the lower anteriors. Okay, and what we want to do is make sure that we've got as close to that as possible. So ideally, our dental technician, when he's waxing in the shapes, if he's going to do a shelf, we'll put that shelf at 90 degrees to the long axis of the teeth. As you are creating that shelf, it is more important to create the shelf horizontally rather than having it at 90 degrees to the long axis of the lower tooth. If you have it at 90 degrees to the long axis of the lower tooth, that looks a lot of the time as though you've got an inclination there. So we will not have contacts down the long axis of our anteriors. Posteriors we do, but again, the masticatory system doesn't have contacts down the long axis of our anteriors. I hope I've helped you with that one. Jeff again, would this patient have benefited from lateral KEF to ascertain anterior root angulation and the level of correction of the crown angle done with the existing restorations in order to plan new crown angulation, subforce along the long axis of the tooth again? From my point of view, Jeff, no. I will work that out in the mouth. And from my point of view, because the teeth are only going to be in contact between 5 to 15 minutes during the daytime, remember, patient's going to have an occlusal splint at night time. Because they're only going to be in contact for that amount of time, I'm not that bothered about getting my forces down the long axis. Again, I tap up and down, you tap up and down, your forces anteriorly are not going down the long axis. So from my palatal angulations, if you like, I work that in the mouth. So I'll put my prototypes on, and I want to get as shallow a guidance as possible. Okay, ready. Is there a normal range of upper lip length? No, it can vary completely, Raddy. Lots of people, lots and lots of people, it will vary. Can you please elaborate on your technique for dentine sealing? Okay, Raddy, standard technique. Okay, so this is not my technique. This is just the standard technique that everybody should be adopting, and it's in 2 parts. So the first part is for cemented restorations. Second part is for adhesive. So there's slight difference between the 2. So you work out, if we're going to go cemented, then I am not bothered about any bond, any dentine bond for actually gluing the crown onto the tooth. So all I'm really interested in at this stage is sealing the dentine. So I will go for the quickest and easiest dentine bond, not the dentine bond that is going to give me the highest bond strength. So from my point of view, If we look at dentine bonded generally, we've got 4th generation, 5th generation, 6th generation, 7th generation, 8th generation, the universal. From my point of view, probably 4th, if I really wanted the best dentine bond, the 4th gives me the best. 5th, not quite as good. So if I'm going to go down the adhesive route, I want my best bond. I'm going to use that bond that gives me the best bond to also do my dentine sealing. However, I'm going down cementation where I don't need to get bonding as such. I just want sealing. I'm going to go for the easiest, quickest. For me, that's a 7th generation. It is finish my prep, wash and dry, paint on the dentine bond, air thin it, light cure it. And that's it, simply done. When I do my light curing, I've put some glycerine over the top and light cure again, so I don't have the oxygen inhibition layer, but that's it, simply done. And it's very, very quick. Remember, we only do it for the dentine. We don't need to do it for the enamel. It's only on the areas of dentine that are exposed. As I said, if we're going to go down the adhesive route, veneers, dentine bonded crowns, then I'll use a different bonding system. I'll use the one which I feel, and again, I'm not saying use a 4th or 5th, you use the one which you feel in your hands will give you the best bond strength. Peter, can you please explain on long centric, wide centric, and free centric again? Okay, so these concepts are there for people who have no anterior tooth contact. So if we have somebody who does not have anterior tooth contact, let's just say the incisors are not contacting, and they're like this, okay? If I want to have a mutually protected occlusion, our 5 principles, been through that many, many times, it means my anterior teeth need to disclude my posteriors. How on earth can my anterior teeth disclude my posteriors if my anterior teeth are not contacting? So number 1 way is get them to contact. Orthodontics, orthodontic surgery, palatal shell, okay? Those are all ways of doing it. Only other way is the long centric. And the long centric means as my patient slides forwards, the lower incisors will slide forwards, not contacting until they hit. Once they're hit, and remember the mandible continues to slide, my mandible can still go down to probably here, okay, watch me. So it can come a long way forwards, okay? So my mandible slides this way first of all, then hits, and then my normal guidance can take place, okay? So how do I get my lower incisors to go from this position to that position? Simply, I rely on my posterior teeth to do the sliding. Now, most of the time, my posterior teeth look like this. So if I have a cusp that goes, a cuspal contact, as soon as I start to slide, that cusp will go on an inclined plane. So normally, if I slide forwards, I don't have anterior teeth, my mandible will do this because it's sliding down an inclined plane because my posteriors are contacting on inclined planes. You know, cusp is fitting into a fossa. So in order to get horizontal movement purely, I have to now take that cusp fossa relationship, okay, and I have to bring up the central part of it. So in fact, we have cusps, we then have a wide flattened area where the central fissure would be, and we have cusps again. So instead of my occlusal surface looking like this, it looks like that with a flat part in between. And now my lower buccal cusp can slide forwards that 2 to 3 millimeters until my anteriors touch. And now at that stage, I will get disclusion. And at that stage, I can now build in anatomy to my posteriors. So my posteriors do not need to look like that, totally flat. We can have anatomy, but the anatomy is around a flat area somewhere on the occlusal palatal area. Wide centric is exactly the same thing, but going sideways. Freedom centric is where you put wide centric and long centric together. I hope that's explained. Tarek, thanks a lot. Okay, cheers, Tarek. Hope you enjoyed it. Radhi, thank you so much. Shista, hi, how are you doing? Was there digital design involved in this case? No, there isn't. Apart from that, I do, yeah, I'm not showing you all the slides. This is supposed to be a 1-hour presentation. There's the normal cosmetic imaging. So it's not digital smile design. is cosmetic imaging. Yes. Katrina, amazing case, thank you. Can you explain again how to adjust the occlusion to have long centric on anterior posterior teeth with composite restorations? Oh, right, okay, wow. I don't think you're going to be able to realistically, I mean, it is feasible to do this in composite at the back of the mouth, okay? It is feasible to do it. It will take a lot of work. You'll need to reduce the lower buccal cusp. Remember, in the case I've just shown you, I'm prepping crowns on the uppers and lowers. So the technician's got space. So he can make his lower buccal cusp look like whatever they need to. They're usually reduced in height, they're not as tall, and the occlusal tables. My technician works it all out, which is great for me. Okay? All I have to do is do a prep. You're doing it yourself. Okay? Now, the occlusal tables, the flat occlusal tables go in the upper. So now you need to go and take that occlusal surface, okay, and take the fissure, central fissure, and move it up to create a flat plane between the two cusps. That means you then have to reduce the lower buccal cusp. Okay? The more that you increase the height of the occlusal fissure, the wider the plane will be. But also, the more you have to reduce the lower buccal cusp by. So it is possible to do it with composite. It's not easy. It will mean that you have to do a lot of adjustments to the opposing teeth. Tarek, how we're going to fit prototypes as those were being made before prepping teeth? Okay, Tarek, always done the same way. Please go and have a look at my previous webinars. We've been through this many, many times. It's the standard way. The prototypes are shell prototypes. They're made in such a way that they will fit loosely over the top of your preps. So they do not fit your preps. They fit very loosely over the top, and you get them to fit your preps by relining them. So these are shell prototypes. Again, standard prosthodontic technique. Okay, Katrina again. In the lab prescription, you have to tell the size of the ramps they need to create. No, technician does that. Okay, technician on his mounted study cast can measure incisal edge to palatal aspect. He measures it. Okay, so he gets his mounted study cast, okay, and just measures that. And now he knows it's 2 millimeters, 3, 4, 5, 6 millimeters. And now he knows how much he needs to do on the occlusal surface of the upper posterior teeth. And of course, when he's doing the waxing, he may need to adjust his wax ever so slightly. Remember, the lower buccal cusp will slide, okay, when it gets to there. Hopefully the anterior teeth are now meeting, and now he can have anatomy. So it's something that he does himself, works it out very, very easy. Do we always need to break the epithelial attachment for a vertiprep and go 2 millimeters subgingival? The vertiprep, Fatima, doesn't have to be subgingival. So you can do a vertiprep at gingival level, supragingival. So it's not the vertiprep, it's where you want the margin to go. One of the advantages of the vertiprep, and I'd encourage you to go back and look at my webinar I did on margins, where we talked about the vertiprep at length. Okay, the advantage of the vertiprep is the fact that you get better sealing around the margin, and therefore the soft tissue and your biologic width, okay, even if you do go and enter and push the limits of your biologic width, then the soft tissue responds really well to it, and you do not get inflammation if done properly. And that's because the vertiprep seals. Most of the time when we've done biologic width scientific studies, we've invaded the biologic width with a horizontal margin. That's a chamfer or a shoulder, okay, shoulder or a chamfer. And those horizontal margins leak, they do not seal. And so we're thinking nowadays that it's not the physical invasion of the biologic width and the epithelial attachment that's caused the problem. It's the fact that they leak and we're getting bacteria in that area. So it's up to you whether you invade or not. I will invade if I'm lacking a ferrule up to 2 millimeters. And of course, this is all, you know, potential treatment plans. You can also go and do other things. You can go and do orthodontic extrusion and then crown lengthening. It is just one extra ability, one extra treatment planning option that you have in your armory to be able to pull out whenever you want to. Okay, Shaza, while creating space for horizontal movements, only palatal cusps maxillary are made flattened in the middle? Correct. Nothing done to lower. The only thing that's done to the lower is the fact that we'll have a flatter occlusal plane in the lower as well. Because if I'm going to bring up the palatal area in the uppers, then that means my lower buccal cusp is going to be shorter. If I don't have as much palatal cusp, then my occlusal surface on the lower will be taller. So I'm going to have a flatter occlusal surface on the upper. I'll have a corresponding flatter occlusal surface on the lower. But I don't actually need to make these flat ramps. So even though the lower occlusal surface will be flatter, the technician will create, with some staining, the effect of making it look so that that central groove is in fact steep. Okay? So it will look no differently, hopefully, the lowers, but the uppers will look different with this flat occlusal plane. Fatima, was the patient restored in RCP? Yes. Didn't increase vertical dimension? No. So restored in RCP, so we did an occlusal adjustment, make RCP and ICP the same, and then we're working at the same facial height. And the reason for this is we did not need to improve her face. If we'd have gone and increased the vertical dimension, in fact, the lower third of the face would then have looked longer than the others, and she'd have looked too chinny and too long in the face. So we didn't need to do it in this particular instance. Fatima, could orthodontic surgery and orthodontics have provided better? Of course. We said as we went through our treatment planning that one of the options was to restore an ICP and occlusal split. Another option was to do orthodontic surgery with or without orthodontics. Another option was to do what we did, which was work with long centric. Patient has all the options. I don't make the decision, doesn't bother me one way or the other. What the decision will be, the patient makes the decision. And, you know, ask yourself, Fatima, given the option of having restorative dentistry with or without orthodontic surgery and orthodontics, which would you choose? People make their own choices. Brindusa, thank you very much. Well explained. Thank you, Brindusa. Shista, if you have freedom in centric, would you potentially get balancing side contacts? No. Sorry, in freedom in centric, yes, if you didn't have the horizontal ramps. So again, we talked about and hope you've got the idea of the horizontal ramp on the posteriors now to allow for sideways, for forwards movement. Okay, so now we have that same horizontal ramp that is wider, that allows the lower buccal cuffs to move to the side. So they are balancing side contacts, potentially, but we would hope that they would just be on the working side. So the technician would be waxing to produce working side disclusion of the posteriors. I hope that makes sense. Fatima, do we need to modify tooth preparation wherever we plan to give a shelf into long centric? Ideally, probably yes. You don't need to do as much reduction, probably a little bit more reduction of buccal cusps and palatal cusps, and you don't need to do as much of the central fossa. So this will come from your diagnostic wax. So this comes from your preparation guide. So if your teeth started off like this, your preps would end up like that. So we're taking a bit more off here and less in the center of the tooth. But that will come from your preparation guide. Remember, our diagnostic wax up gives us the shape for our preparation guide. Next one, Shista again. Thank you for the treatment planning case discussions, really enjoyable. No problem, thank you for attending. Fatima, thank you, sir. Sandra, thanks, Prof. Lovely case explained. Okay, unless there's any more questions suddenly coming in, then I'm going to wrap it up. Okay, guys, thank you for listening, and I hope you've enjoyed it. We've got more webinars next week. I'm going to be talking, I think, 2 or 3 times next week. So please, if you can, catch them, and hopefully it can be of some service, some use. Okay, take care. Thank you very much indeed. Have a good day.